We're going to waste no time. We're going to get in with a couple of talks around difficult problems in the emergency department, which may not look that difficult when they first appear. And first up is Professor Matt Reed. He's Consultant NRS Fellow in Emergency Medicine. He runs Emerge Up in the University and Emerge Up in Scotland and works at the University of Edinburgh. And Matt, you're talking about syncope, and we see it all the time, but some days it's a little bit more complex than it first appears.
Great, thanks very much, Simon. Ladies and gentlemen, Your Royal Highness. First of all, just a few disclosures. These are just related to devices that I've had for research studies. So to start with my objectives, so I think a lot of us find managing syncope difficult, and I'm going to go into a little bit about the reasons we do. I'm going to talk to you a little bit about my suggested strategy about how to handle, I should just say here, adult patients. I'm not touching on children today. And finally, I'm going to hopefully give you a couple of pearls to take away with you. So let's start first of all about why we find managing syncope difficult in the emergency department. Well, first of all, it's common, so we do need to know quite a bit about it. This slide here shows you that syncope is just outside the top 10 presentations to our emergency department in Edinburgh. Almost 500,000 people present every year to emergency departments. And this is one of the reasons that we really worry about it. We're worried that we're going to miss a serious cardiac cause. We're going to send the patient home and they're going to have a cardiac arrest or a bad outcome. So we'll just get all these out of the way first, shall we? Those difficult ECGs that we mustn't miss. So this is the first one. This is hypertrophic obstructive cardiomyopathy. And this was what Fabrice Maramba had, who had a cardiac arrest secondary to it. There's some voltage criteria there for left ventricular hypertrophy in the lateral leads, and also some Q waves as well in the lateral leads there. This is another one. Hopefully the arrows might help you with this one. So this is congenital long QT syndrome. Again, very difficult to pick up in the ECG in the emergency department without 24-hour tapes or more prolonged monitoring. This is Dana Vollmer, interestingly, who won a gold medal in the 2012 Olympics with congenital long QT syndrome, which was known about and managed. Staying on the sporting theme, this is former cricketer James Taylor, who went to an emergency department in Nottingham with ventricular tachycardia. And here you see he's got an ECG which shows ARVC, so arrhythmogenic right ventricular cardiomyopathy. And the things to take home here are the T-wave inversions in lead 1, 2 and 3, which isn't specific for ARVC. We see about 70 to 80% of people, but the little epsilon wave there, which is pathognomic for ARVC, and we've seen about 30% of patients with it. And finally, the last ECG I promise, this is Brugada syndrome, type 1 Brugada syndrome, which you may be familiar with, the ST elevation and the T-wave inversion. So another reason we find it difficult is that patients come to us, they've had their episode, they may be coming by ambulance. By the time we get to see them, most of them are completely settled. We're not able commonly to find anything on examination. The ECG might be normal. So we're left in a bit of a quandary about what we do. They seem absolutely fine, they want to get home. Another reason it's difficult is that very commonly, unlike this poor weather forecaster live on television, we don't always have a witness history. So there's not always a relative there. So we must always look at the paramedic sheet so we can get that bystander information, interrogate the security cameras at Marks and Spencer's or something like that. Certainly our rapid assessment neurology clinic, first seizure clinic, do that very, very well to try and get a video of what happened if it was in a public place. But that's not often the case. So bystander, witness, really important. Okay, so lots of reasons why we find it difficult. We struggle with it. So what can we do? What positives are there? So first of all, this slide just demonstrates that we don't need to be quite as concerned as we might have been. Now, if you've read some of the literature from the 80s in this area that has that we seem to know about, there's figures of about 30%. So if you've got a cardiac cause for your syncope, your 1-year mortality is 30%. So really alarming, certainly alarming if we're seeing someone in the emergency department, and makes us more likely to be concerned about missing something. But this is some data from the ESC guidelines a review and meta-analysis of all patients, all studies that have enrolled syncope patients. And if we actually look, most studies actually include patients who we know the cause. So if you've had a massive PE, you've come into the emergency department, back in the 80s, 90s, and in the early 2000s, we enrolled you to syncope studies, even though we knew that you had a PE. So in fact, if you look at non-fatal severe outcome, about 2/3 of it we actually knew about in the emergency department, and it's only about 1/3 that then becomes apparent afterwards. So just to put it in a bit of context there. So what other things can we use to help us? Well, you'll be familiar with some of these clinical decision rules. There are lots of them. That normally means that none of them are particularly good at doing what we want them to do. One of the latest ones, probably one of the best, and certainly one of the most researched and validated, is the Canadian Syncope Risk Score. That's the link to a really nice little sort of MD Calc type calculator to be able to calculate it. There's no doubt that it does characterise patients and prognosticate, but where we cut off the threshold for admission is a difficult thing. Now, all of these clinical decision rules, none of them are better than clinical judgment, and also we know that they are likely to over-admit patients compared to clinicians. So I suspect most of us are not using these rules formally in the emergency department. What has been really beneficial from these is that all of the tools and all of the components of the tools we've become really aware of. So I think generally as physicians in emergency departments, we are much more aware now of all the risk factors associated with syncope because of rules such as this, and that's helped us be able to make more informed decisions and improve our clinical judgment. Right, so this is my approach. It's fairly straightforward. I like nice and straightforward things. So first of all, I ask myself, is it syncope? So we need to make sure that's what it is. There are loads of syncope mimics, and it's important that we take a really good history and we drill down to exactly what the problem is. Now, we call it transient loss of consciousness, and that really is an umbrella term for syncope and seizure, and we call it that until we're happy that it's either syncope or seizure. But we must also make sure that we don't just put everyone into the sort of the bucket that's a sort of collapsed query cause, just because we can't really be bothered to get into the really minutiae of exactly what happened to elucidate which of these things it is. So let's just touch on, first of all, seizure and syncope. Are there any easy ways to tell the difference between the two? There's lots of suggested things. I think the most important thing is if the patient hasn't recovered consciousness quickly or is not quite right, not back to their normal self within about 15 minutes. There's some other things. This is tongue biting, so if you bite the front of your tongue, it's supposed to be more likely to be in a syncope, and if it's the sides, it's seizure. There's lots of things such as that and incontinence things, but for me, it's about recovery and how long afterwards it takes the patient. Another important one is the timing between the collapse or the fall to the ground and the seizure activity. So this is a tennis player you can see here having a vagal episode, and then you can see the twitching, the myoclonic jerks after she's fallen to the ground. So this is syncope with myotonic jerks. With seizure, you get the movement, the shaking first, then you have the loss of consciousness. Not an advert for sports medicine, that one, perhaps. So next we want to ask, is there an obvious diagnosis? And here we've talked yesterday, Catherine talked about the serious things that we don't want to miss. So, for example, chest pain going through to the back associated with syncope is aortic dissection until proven otherwise. Severe sudden onset headache with syncope is subarachnoid hemorrhage until proven otherwise. I could go on. If you found complete heart block on the ECG, you've made your diagnosis, and then obviously we just follow the treatment according to that diagnosis. But there will be people who we're definitely happy it's syncope. We don't have an obvious underlying cause. The patient seems to be fine. We haven't found anything on examination. So now the question we need to ask ourselves is, are they high risk for a cardiac cause? Again, three sort of different groupings for syncope. So I, again, make it nice and straightforward. So the ESC divides this into reflex, so that would be your vagal type syncopes. your orthostatic and cardiac. And cardiac we divide obviously into rhythm disturbance and also structural causes. So we're really not that vagal, reflex and orthostatic are not important. These are really associated with morbidity if you're having them really regularly and really affecting your life. So we mustn't just dismiss patients who have these forms of syncope. And we can do things for them, including giving them a good advice. But we're really interested in picking up whether this is a serious cardiac cause. So how do we do that? So 5 things that I think are really important we must do in the emergency department. So we must take a good history. Number 2, we must take a good history. Number 3, we must take a good history. So I can't labour it anymore. It's so important to drill down into the history and find out what the events surrounding the few minutes the event happened. We must always do an ECG, obviously. There are obviously people who go to seizure clinics who have cardiac causes picked up when they get their first ECG. So if you think it's seizure, still do an ECG. And finally, do an active stand. Now, NICE have perhaps de-emphasised this a little bit in their latest guidance. But I always do an active stand, so a 1 and a 3 minute stand, and I do that myself rather than asking the nursing staff to do it. And I think that's really important because then you can get a bit more history from the patient, and also you can see what they're like with it when they have a drop. So, for example, if you've got someone who's got a 20 milliliter mercury drop, but they're really symptomatic, then likely is that you've got a postural cause. The nursing staff come back and says they've got a 30 drop. What were they like when they had it? Were they symptomatic? And again, you're really not sure where to go. Syncope during exercise, we all know, is a serious cause. Having a reflex syncope is really common, actually, after athletic event or after sporting event. So we do see a lot of it. So again, the history is vital to see when this happened. If it happens during exertion, it is cardiac syncope until proven otherwise. If you look at the right side of this video here, you'll see this is the Luton defender Tom Lockyer, who, this was a playoff final at Wembley, had a loss of consciousness on the field and was diagnosed with cardiac syncope. Unfortunately, went on and had a cardiac arrest a few months later, from which he did well. But you can see clearly here, there's no one around him, there's no trauma involved. When he goes down, he stays down. Clearly, he's had a loss of consciousness here. It's during exertion. This is cardiac syncope until proven otherwise. Another thing I think is really important to determine whether it's a cardiac cause is how long the pre-warning is. And this really struck me when I saw someone last year who had both vagal and cardiac causes for their syncope up until they had a pacemaker put in. And they would very clearly describe that when they had a cardiac cause, they knew nothing at all about it. The next thing they remembered, they were on the floor. A bit like the poor rugby chap we saw yesterday who face-planted, have facial injuries, unable to put their hands down because they've had a sudden loss of consciousness without any warning. Whereas with vagal or postural, you tend to find that patients have much longer, prolonged prodromal period. There's a video here to demonstrate this. This is a politician in the Dutch parliament who
Dus ik denk dat het goed
has a
is
vasovagal during giving a speech. And you can see some of the characteristics of vagal syncope here coming along. So the speech starts to slow, starts to become slightly pale, starts swaying.
Ik zie u twijfelen. U wilt wat zeggen. Ik schors de vergadering.
Okay, so you can see that there's I've sped that up a little bit as well. There's quite a prolonged period beforehand. And sometimes we all see people coming in on after Sunday afternoon meal in the pub with a family, and someone's had a syncope episode there, and they've said it was just happened really suddenly. But when you actually go into it, you find the family say, well, actually, they've been quiet for the last 5 or 10 minutes. They weren't saying very much. Yeah, they looked a bit pale, actually. I just wondered if there was something happening. And when you go to speak to the patient and really drill into it, they tell you that actually the symptoms were ongoing for a period of time beforehand. And we're quite comfortable then. And don't be uncomfortable about diagnosing an elderly person with vasovagal or postural syncope. Okay, just because they're old, it doesn't mean that they've got cardiac syncope. A few other things we must remember. Always ask about previous events. Again, that's the patient may have had a cardiac cause and it wasn't picked up the first time. So again, the history from the time that they've come to you, the index calls, might not be as clear, but they might be able to give a really good account of events of something happened 3 months before, or they may have had a family member with them that time who witnessed that event, but not this one. And family history, this is the index case for congenital long QT syndrome. And this, the girl in the middle, unfortunately, had a cardiac arrest. And it was found afterwards her brother, a few years before, had also had a sudden death due to after a sudden shock. So that's how congenital long QT syndrome was found out about. ED examination, it's important, but really I'd focusing on listening to the heart sounds, cardiovascular examination, and obviously a neurological examination if we're going more towards neurological cause. Investigations, there's not really many that are particularly useful. American CT everybody, there's no need. Brain CT. The San Francisco syncope rule includes hemoglobin. We probably should be able to detect clinically if someone's anemic. Troponin. Who does troponin on syncope patients? Or maybe not go there, that's a whole talk in itself. Troponin is prognostic. It's prognostic if you've got a hip fracture. We know it prognosticates your outcome, but it's just telling us that people are older and they've got multimorbidity. We do know that with cardiac arrhythmias, that can put your troponin up, but it's not really able in the emergency department to discriminate between a cardiac and a non-cardiac cause, so I wouldn't do it unless they've got chest pain and we're thinking of an ACS. So what's new in the world of syncope over the last few years? Well, I'm going to touch on a few things. Interestingly, we have found the mechanism for the Benzold-Jarrod reflex that we might have heard about at medical school, so your reflex syncope. I won't go into that today. The ESC guidelines, these are a few years old now. There is an emergency department section in them, and it gives you the low and high risk features for the event itself, past medical history examination and ECG. I find this really useful. Just worth looking at these couple of pages in it. And they suggest if you only have low-risk features, you're probably safe to go home, likely vagal orthostatic. If you've got a high-risk feature, you don't necessarily need to come into hospital. We're probably admitting too many patients, but we need a really good mechanism for following up these patients very rapidly afterwards. We know from the ASPIRED study, which I've just mentioned at the end, that the NICE guidance of seeing these patients within 4 weeks with monitoring by a cardiologist, we're not meeting anywhere really across the whole of the UK. If you've got access to a syncope service where someone could be seen quickly, that is sufficient, and you don't have to admit everybody. Have a plan in your emergency department so your teams know what to do with patients with different type of high-risk features. The ESC also has some really good guidance and patient information sheets which you can crib for your own department for those with vagal and postural. This is the NICE guideline. This was just out last year. There's not a huge amount of new stuff in there, worth a look. Other new stuff. Well, there's some things that we're still doing a lot of old stuff for. So this is Norman Holter of Holter Monitoring fame. This is an Air Force battery pack, which he then devised a ECG monitor. We've not moved on very much. This is probably standard that most of us are using at the moment in 2020s. So we can do better. So rather than just stratifying patients, we could probably get better at trying to find the underlying cause. And we do know there's a bit of evidence out there in the last 10 years that the chances of us picking up an underlying arrhythmia are more likely as soon after the index case as possible, which is why it's such a shame we can't follow up these patients as quick as we should be. This is a ASPIRED study. We've finished recruiting to this over almost 2,500 patients in 50 EDs across the UK, and they're all getting a 14-day monitor as soon after the event as possible to see whether we can reduce the number of episodes and we can pick up more causes to actually make more diagnoses in these patients. And that's important because there is a good qualitative data coming out now. This is a study from Sheffield talking about the patient's experience of their first episode after a transient loss of consciousness. And I think this is probably the case for lots of conditions that people come to the emergency department, but they feel anxious, they're left without answers, their frustration that they're sent away without anything, without any tests, or huge delays for test referrals. So really important to explain to them exactly what's happened, what is it we're worried about, and how we're going to follow them up. We did the same for a qualitative part of the spine. We're finding just the same things about this anxiety that patients have, and also anxiety about having it happening again. They're worried this will happen in a public place. and obviously they've lost consciousness, so they have that real fear with that. And I think that also showed there's a real fear from clinicians as well, and anxiety about what can we do with these patients afterwards, because we know we're going to send them off maybe to a clinic, but they're not being seen for a while. There's some good examples of practice with rapid access syncope clinics, RASCLs. This is one in Glasgow, and this shows that you can obviously reduce admission, reduce bed days as well if you've got a really good syncope service, but it has to be multidisciplinary, so geriatricians, cardiologists, electrophysiologists, and the access to tests in that clinic as well. We can't have a talk on syncope without talking about driving. So with every person we see in the emergency department, we need to think whether their driving ability is impaired. If you've got unexplained syncope, you can't drive for 6 months. This is our guideline. The link takes you to the DVLA, so you should always think about that with everyone you see and document it in the notes. We're really bad in our department as well at documenting it. We only do it in about 10 or 20% of patients. So we must remember to do this for these patients. So to summarise, we do find it difficult, but if we take a good history in the department, then we'll be absolutely fine. We'll be able to hopefully make the diagnosis, or at least decide whether we're concerned about a cardiac cause. And this is my approach. Is it syncope? Is there an obvious cause? And if I don't have one, do I need to be worried about a cardiac cause of syncope? Thank you.
Thank you very much for an interesting talk. We've got a couple of questions, and the first one that came up was, can the information from everybody's smartwatch be useful?
Yeah, brilliant question. So unfortunately, no, because so the Apple 4 watches, or the new Apple watches, are great for patients who've got palpitations, because you need to be conscious, so therefore you can record your ECG. You know, when you're in Sainsbury's, you have your episode of SVT, you record your palpitations, brilliant, we've got the diagnosis. Trouble with syncope is that you've lost consciousness, so anything that's an event recorder won't be able to pick it up. And unfortunately, there aren't really long-term monitors on watches. We have heart rate recorders, but I always find them really difficult in terms of, you know, if someone's got a raised heart rate, we still don't know what the underlying rhythm is, which is what it's all about. With these patients, it's all about getting a rhythm-symptom correlation.
Thank you. And I think Simon had a question as well.
Is there anything else on that?
Nope.
No? OK, so quick fire round. You can answer yes or no, if that's OK. PE as a cause of syncope. There was a paper in 2016 that said 10% of syncope patients have got PE. True or false?
False.
Good, thank you very much. When you're doing your BPs with the patient, 100% agree with that. Are you happy using the oscillatory, can't pronounce that word, blood pressure monitors, or do you prefer a manual?
I do it automatic.
Fantastic. If you see somebody who comes in and they've not actually presented with a syncope this day, but the QTC is slightly long, but they're not coming, and they say, yeah, I did sort of pass out about 3 months ago. Are you worried?
So if they've just come with ankle sprain, not worried at all. We do
Fantastic.
ECGs and diagnose everyone with ankle sprains with long QT syndrome. If they come in with a collapse, I refer them to 24-hour tape. OK, and maybe not a yes-no question, but when that video comes back, and people are incredibly good about getting videos really quickly these days, aren't they? Often police will come in with the video from your Ring doorbell and everything else. Can you tell on the video that people often say they've been jerking around? Can you tell the difference between jerks from seizure versus... What are your tips for differentiating between seizure and syncope when they're jerking around on the floor? It's difficult. I probably don't see a lot of those. That's probably something that the seizure clinics see much more than we do. My understanding is, like on the video, the myoclonic jerks are much more short-lived, completely different, I think everyone would acknowledge, to a proper tonic-clonic seizure. Yeah, so that's really helpful, potentially, but we may not get it. Absolutely fantastic. And what's come through now? Perfect. So last question was, what's the incidence of cardiac syncope with a normal resting ECG? That's a great question. It doesn't rule it out, obviously, but having a normal ECG is very reassuring. Yeah. Thank you very much. Excellent. Thank you very much.